Hi everyone, this is Karen O'Hara, Director of Marketing and Communications with WorkCare. Welcome back to our weekly briefing on preventing and managing COVID-19 in the workplace. Many of you join us every week. If you're just joining us for the first time, we're really happy to have you participating. This is our 32nd consecutive webinar. Today's topic is going to focus on herd immunity. The session is being recorded and you'll be on mute through the webinar. Please submit your questions using the Q&A function in Zoom. We'll answer as many questions as we can at the conclusion of the formal presentation, which typically lasts about 30 minutes, and we preserve about 10 minutes for questions. All questions are also answered in writing and posted on our website, and the recording is posted on our YouTube channel, and those links will be available to you during the webinar via the chat function. Any questions we don't have time to answer, Dr. Harris and I will answer and include them in the Q&A that we post on our website within a couple days. Our speaker every week, and this week, is Anthony Harris, MD, MBA, and PH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and Associate Medical Director for On-Site Clinical Operations. He's also our lead clinician for our COVID-19 response. And now I'll turn it over to him. Thank you.
Excellent. Thank you, Karen. And thanks, everyone, for joining us again. We're happy to present today some information around herd immunity, but also the impact of herd immunity, what it would look like. And we want to paint a full picture from a clinical perspective of what it's going to take to get to herd immunity here in the U.S., and we'll look abroad as well at some examples. And so we want to jump into the same format. If you're joining us again, thank you, and the format is still not going to change. If you're joining us for the first time, the format is pretty straightforward. We go through a clinical update followed by some pathology and microbiology. And then we'll look at, from an epidemiology standpoint, what and how we're performing from both the U.S. and global perspective. Finally, we'll jump into some information that we need to know with regard to prevention and conclude with some strategies from a workforce standpoint and what WorkCare, how we've been assisting our clients and employers with keeping their workforce safe. So, with that being said, let's jump into today's update. We want to talk about, for our clinical presentation, something that we haven't touched on very much over this series, and that is the impact to children, particularly young children, infants, okay? As you may know, having joined us over the last couple of weeks, my wife and I celebrated the arrival of our son, who will be a month old this week. And we want to talk about the preventative strategies that we've deployed in the workplace to help protect our friends and family, and yes, even the young. So what happens with regard to very young and those under the age of 18, we want to look to a recent study that was conducted, published, and look at what they found with regard to the impact of coronavirus to this demographic. Now, we all know, and we've talked about the clinical presentation not being as prominent as severe in the younger population as those who have pre-existing conditions and or are older, 65 or older, in those demographics. But we still want to point out that there is disease present in the younger population that's significant. And so we want to make sure we're all protecting these individuals as well. So if we summarize the findings in this particular study, 576 cases were reported between March of this year and July of this year with this demographic, and 8 out of 100,000 individuals that were positive for COVID-19. Again, that 576 number. 8 out of 100,000 was the rate at which the individuals were admitted to the hospital. Okay, and so if we look at a 2 and under demographic, that number goes up to 24.8 out of 100,000. Now that's in comparison to adults older than 18, and certainly those 65 and over. The rate is about 140 per 100,000 admission to a hospital. 33% of those individuals that were admitted to the hospital ended up in the ICU. So a third, one out of every three admitted, ended up in the ICU. 5.8% received some type of invasive mechanical ventilation. So they were put on a ventilator because their lungs were full of fluid and obviously needed assistance breathing. And then if we look at the demographics subsegmented into race, we see that yet even in the younger population, as we have presented previously with older adults, Hispanics and Blacks are adversely affected, 16.4 and 10.5 out of 100,000 admitted to the hospital in the Hispanic and Black demographic versus 2.1 in the white demographic. Okay, so we want to present this because, again, as we talk about herd immunity, where we're headed in regards to a potential herd immunity, there's going to be quite a toll on both the old and the young, and we need to be cognizant of that. Obviously, we talked about risk as we sent our children back to school. Obviously, a lot of school districts still doing virtual learning, but we want to move forward with the full understanding that it's impacting, COVID-19 is impacting all ages, albeit differently. If we look at some additional things we want to talk about from a clinical perspective, we want to talk about hospitalized COVID-19 patients and ongoing symptoms, right? We want to update you on the latest here. This recent publication stems from Oxford University research that looked at patients that were hospitalized, 58 in this case, and what we see is that 64% of patients that suffered, 64% of patients in this study suffered persistent breathlessness, and 55% reported significant fatigue 2 and 3 months after their onset of COVID-19. So we're still seeing this long-term symptomatology for those who are hospitalized. If we look at MRI findings, abnormalities were seen in the lungs of 60% of these patients, in the kidneys, 29%, and in the heart, 26%. The liver was also affected, 10% in 10% of these patients. So there's a spread still significantly of morbidity in hospitalized patients. And so how does that translate to your workforce? Obviously, if you have individuals that are affected by COVID that end up becoming hospitalized, they're going to suffer potentially long-term effects. Symptoms are going to be long-term, drawn out more than half of the time, and their return to work is going to be prolonged, right? And so again, when we talk about the actual cost, if you're self-insured, that's going to be a tremendous cost to your organization. And this undergirds the need for prevention in every way, shape, and form when we talk about workplace transmissions. Obviously, we can't control to an extent the community transmissions, but certainly we can affect community transmissions through our education of the workforce with regard to accurate information from the impact of COVID-19. So let's jump into some updates with regard to, from a pathology standpoint, microbiology standpoint, what's important to our workforce that has received some perhaps misinformation or not accurate information, and we want to update you on travel, okay? When we talk about workplace travel, should we do it? Should we not do it? What's the answer, Dr. Harris? And so we want to give you some solid guidance on travel and guidance on how do you treat travelers with regard to quarantine and isolation and the whole nine. So if we look at some recent publication with regard to travel and the risk of COVID-19 transmissions in travel, Dr. Friedman, who's at the University of Alabama, published data that helps us articulate what the risk is from airplane travel in particular. Okay, and if we look at his approach, he captured data from multiple reports, multiple studies that looked at transmissions that actually happened from airplane travel from individuals who were captured and tested and confirmed to have PCR positive COVID-19, and then looked subsequently at were there transmissions that occurred on that particular flight. And there was numerous studies that were examined by Dr. Friedman. We won't go into detail into every one of them, but we want to highlight some salient points here so that we can begin to shape our approach to workplace travel, particularly around airline travel. Is it safe or not? Do we allow it? Do we quarantine thereafter? So Dr. Friedman looked specifically at several factors. One of them was the origin, destination, transmission level, origin and destination transmission level. Obviously, that's important from which someone departs and then they arrive as to determine whether or not they actually transmitted during the flight or during the airport portion of their travel. They looked at flight number, origin, destination as well, aircraft type and total in regards to transfers, and then number of likely people affected before the departure, number of in-flight transmissions, and the level of likelihood there. Also looked at quarantine and testing protocols upon arrival. The seat location even was analyzed when available for the secondary case. Secondary case meaning the individuals who contracted potentially COVID during their travel on the flight, whether or not masks were required on the flight, and then we want to jump down to some of those findings and what he saw. Again, we won't go through every case, but what we see in pattern is that there were many cases of COVID-19 that were found and proven to be present on flights that departed from various destinations. In this case, 11 symptomatic PCR positive individuals, travelers, were found upon arrival. And in this case, there were no transmissions found. There was another case of 2 positive PCRs on a flight that was back in January. Again, no transmissions. Several flights were tracked in this particular study. 10, 19, 13, 9, 7 individuals. These are multiple flights with 10 people, 19 people, 13 people with PCR positive cases upon arrival. And again, what was found is that no transmissions on these flights, 5 in total, were detected. And so we want to look at that from the perspective of were masks required, optional in one case, mandatory in another case, optional again in the cases with no transmission, and mandatory with no transmission. Okay, so when we look at this body of data, it's not complete in any way, shape, or form, right? And the author, Dr. Friedman, does speak to more research necessary to fully understand and to fully capture prospectively the true risks of travel and transmission of COVID-19. But we can draw some general guidance as he has concluded in his research with regard to travel on a plane. And he says the absence of large numbers of confirmed cases published in published flights of transmission is encouraging, but not definitive in terms of evidence that flyers are truly and holistically safe. Yet and still, at the present, based upon circumstantial data, strict use of masks appear to be protective. Okay, and you all may be familiar if you travel now in the U.S. via airplane, public flights, you're required to don a mask both in the airport as well as on the flight. So, what does this mean in relation to your approach to travel, workplace travel? Air travel should not be considered high risk for COVID-19 transmission. All right, and so we want to emphasize that If you're considering someone high risk solely from a flight, that does not line up with the potential for transmission from air travel. Furthermore, quarantine protocols should not be based upon air travel alone. Okay, so everyone does not need to quarantine just because they hopped on a plane. And destination and behavior at said destinations should be considered when determining protocols for quarantine. Okay, so it's more important to look at what your folks are doing prior to and after their travel, their reason for travel. Did they go to a wedding, right? Were they wearing masks? Were they in large groups? Those factors are more important than the airplane or the air travel portion of their travels. If they're traveling for work, obviously, realizing and being cognizant to their proximity to other workers when they arrive, what protocols are in place, if they're contractors at the destination as well. Those factors need to be captured and considered when you're talking protocols. And if you're over restrictive with regard to travel, consider dialing that down to allow more workplace travel to occur. And I'm not trying to be a spokesman for the airlines, right? What I am trying to emphasize, though, is that we have to have the best strategy for you in the workplace to administer, keep your folks safe, but at the same time allowing you to be productive in the businesses that you're conducting. And so when we talk about recommendations around travel and we look to recommendations from the CDC, CDC has even updated their recommendations to say public transportation altogether should require masks, right? And if we dial into the CDC, their interim guidance specifically points out that any passenger on public conveyances, airplanes, ships, ferries, trains, subways, buses, taxis, etc., should be required by the operators to don a mask, essentially. And specifically, they want to support those operators to disallow anyone from boarding, disembarking, or participating in travel if they don't have a mask. So we know that masks are obviously important, and we rely on them to help reduce transmission. And it is, in some way, shape, or form, and it's to a significant level, a good strategy to allow people to travel safely and have reduced opportunities for transmission. So now let's dial into some epidemiology. Let's look now at the US, where we existed 2 weeks ago with 7.7 million cases, 5.2 cases on average in a trailing 7-day per 100,000 individuals, and 219,000 deaths, 214,000 deaths at that time, increased last week to 8.1 million and 17.3 per 100K, and continues to increase today. Apology, I think I doubled up on a slide there, but we're at 8.1 million cases here. In terms of deaths, we looked at 0.2 2 weeks ago. That increased as well here over the last several weeks. Dialing into the daily new confirmed cases here, with regard to the US, we were going back and forth with India in terms of a 7-day rolling average. We continue to do that last week, and this week we're now slightly at the same level, slightly above on that 7-day rolling average as India. If we look at the number of deaths, we saw, again, we recognized that we were spiking in the US, that the deaths were going to lag behind, and we certainly saw that leveled off trend, and now we're seeing slight uptrend this week in the number of deaths here on that 7-day rolling average. If we look at then the positive, going back to the percent of positive tests that we are conducting, we were trending in the wrong direction 2 weeks ago, continued to trend in the wrong direction last week, and sharply trended up again in the wrong direction this week. And so if we zero in on that, we know that worse times are in store because we are not controlling the virus on a number of metrics here in the US, and certainly you're seeing that play out in multiple communities here. If we look at total number of tests, we want to point this out because I know some of you are already saying, hey, Dr. Harris, that trending up of percentages of tests is only because we're testing less in the US. And the answer to that is no. We are testing it roughly at the same level we have been 2 weeks ago and last week as well. We crested 1.09 million tests on a daily rolling average, 7-day rolling average last week, and we're hovering around that 1 million mark here still. So it's not attributable, so the increase in positives is not attributable to a decrease in total tests conducted. It is likely attributable to poor control of the virus and truly increased number of cases in the US. So from a preventative standpoint, does this mean we are on track to reach herd immunity at some point here soon? What's the prospectus on that? You've heard it in the media. You certainly heard various, let's call them experts on both sides of the aisles, speak to herd immunity. So let's get to the nitty gritty of it. We've touched on herd immunity previously, but we want to point out CDC's definition of herd immunity. They actually refer to it as community immunity, a situation in which sufficient portions of the population is immune to infectious disease through vaccination or prior illness to make it its spread from person to person unlikely. Even individuals not vaccinated, such as newborns and those who have chronic illnesses and can't be vaccinated, offer some protection because the disease has little opportunity to spread within the community. Okay, and so we're going to emphasize this and articulate this so that everyone is on the same page and can communicate effectively to your workforce the true meaning of herd immunity, why it works, why it's important, and whether or not we're going to reach herd immunity with regard to COVID-19 anytime soon here in the future. So let's revisit something we presented probably at this point 2 months ago, I believe, the R0, or the reproductive rate of a particular illness. It's predicated on two factors, really: how susceptible the general population is to that particular illness, and then distance, space, right? The number of contacts that an individual may have, right? And so we looked at this equation several months ago, and we looked at specifically COVID-19 in the middle here towards the left, having an R0, or reproductive rate, of 2.5, meaning one person will on average infect 2.5 people, okay? As opposed to measles, which is high on the 16.0 level of infectiousness. And when we zero in on COVID at that 2.5, we also learned and presented that that is on the low end, that 2.5. We looked at studies that showed that COVID-19 in different demographics, both in China as well as in the US, had different levels of the R0, ranging from 2.2 to 2.7, and in some cases 5.7. And we're pointing this out because it's significant to speak to herd immunity. The study that looked specifically at the US found that in places like New York, the R0 was high as 6.4, okay? And so what we understand about the reproductive rate of a illness is that it will directly proportioned to the number of people that need to be affected or be vaccinated by an infectious vector to achieve herd immunity, okay? And so the whole notion of herd immunity is the more we have people in the community that are immune, the more we're going to actually protect those who have not yet been infected and are still healthy. Let's play that out visually, okay? So looking at this picture here, we have different percentages increasing of people vaccinated in the general community, okay? And so if we don't vaccinate anyone, everyone's susceptible, and what you're seeing in red is the actual connectivity, if you would, and spread of a particular illness, all right? So the blue dots are unvaccinated, yellow dots are vaccinated, and the black dots are the people who become infected. And so as you can clearly see, the more you have vaccinated individuals, the less you have actual spread of a particular illness. And in this case, once you reach that 70 to 75 mark, you're starting to see that herd immunity really take effect, right? Now, herd immunity again, is predicated on the level of infectiousness of a particular illness. And so when we talk about the cost of COVID herd immunity specifically, there's a significant burden of disease that's going to be required in order to get that herd immunity if we're not getting it from a vaccination in particular. Okay, and so this is another depiction that I think articulates well the value of herd immunity. So those individuals that are blue are not immunized and healthy. Those individuals yellow are immunized and healthy, and those who are red are the ones who are not immunized and become sick and contagious, right? And so as we see that the number of individuals that increase in the general population that are immunized, we actually are protecting those who are not immunized but still healthy in that bottom right of this particular picture, right? It's almost like a barrier around those individuals because you have immunized individuals, and the sick individuals don't have contact directly with those who are healthy. That's the concept of herd immunity. So now let's look globally. Let's zoom out and let's see if herd immunity is a reality when it comes to COVID-19. Early on, Sweden is a good case example of an attempt for herd immunity, right? Sweden led the charge into COVID-19 without putting in any lockdowns in place. And this was back in July of this year, right? When we looked at what Sweden was attempting to do in their health ministry. Herd immunity was the hope, okay? That they would have enough people in the population that got infected with COVID-19, and the number of people infected and recovered that had immunity would protect those who were not affected, okay? And so did it work? And the answer is no, because what we saw play out in Sweden is that they had a far greater death rate in their population than their neighbors. Okay, if we look at Sweden, they outpaced their neighbors to the tune of 567 deaths per million compared to 106, 59, and 47 deaths per million in neighboring nations. Okay, and so again, they're rivaling with this number what happened in Italy, and again, their population density is not near that. So we know that from this example, as it played out in reality, an attempt to get natural immunity in the general population sufficient to reach the level of herd immunity, which again doesn't really start until you get to, at a minimum, 60% of the population immune, and certainly closer to 70%, then it just is not feasible to have that natural immunity play out without a significant death toll, a significant morbidity and mortality amongst the population. So what does this translate to, right? That 50%, 60%, 70% immunity means that 200 million Americans would have to be affected by the virus in order to achieve herd immunity in the US alone, okay? And that does not even speak to what we've presented here recently in the past in this presentation in regards to how long immunity actually lasts, right? We have seen reinfection of COVID-19, as we talked about that Hong Kong case about a month or so ago. And we know that science is showing us immunity is lasting for about 120 days, 3 months at a minimum, right? And so let's dig into that. Let's dig into some updated data around that. This study looked at the decline of humoral responses for those individuals who were affected by COVID-19, and they were trying to capture some of those convalescent antibodies. You've heard of that most likely by this point as a means to treat those who are hospitalized and severely affected by COVID-19. And what this study, although this study wasn't specifically looking to articulate how long does immunity last in individuals that have been affected by COVID-19, their data gives us some updated perspectives on how long humoral responses may in fact be and exist for those affected by COVID-19. And so what they observed was that the receptor binder domain of the antibodies, IgG and IgA particularly, decreased at 6 and 10 weeks after the onset of symptoms. of COVID-19. Okay, IgM levels decreased more abruptly. All right, and so if we look to this as an example of our own humoral response to an infection of COVID-19, it is consistent and it undergirds that immunity is probably not long served, going to be long served for us. And again, that works against the concept of having herd immunity in the population, not only from natural immunity, but also potentially from antibodies that are generated from a vaccination, okay? And again, this particular study looked at antibodies against that spike protein that we have spoken to before, the spike protein that is mutated 18 times based upon genetic analysis that we've seen so far since the beginning of this in Wuhan, China. And that continued genetic drift and genetic shift in the virus will likely lead to, again, the same picture that we have with regard to flu vaccinations, needing to revaccinate on a recurring basis in order to maintain herd immunity. All right, and that's what we want to highlight here. And so let's look at some data, updated data on the prospect of where we're heading with regard to impact in the U.S. Impact in the U.S. In terms of deaths. Okay, so by February 1st of next year, 389,000 deaths is what's currently projected, and we've showed this, represented this data before. We just wanted to quickly present this again to overemphasize that trying to get the herd immunity through natural herd immunity is not going to be feasible for us without a significant toll on our population. So what does that mean for us from a workplace strategy standpoint? It means that we got to double down on what we've been speaking to, our secondary and our primary prevention to prevent workplace transmissions, and education to help prevent community transmission to your workforce, right? And at the end of the day, what it boils down to is a race to vaccinations. That's what's going to get us out of this and on the other side of COVID-19 to the extent that we can start to imagine some life going back to normal in regards to social distancing and wearing masks and things of that nature, right? Again, herd immunity from vaccinations will hopefully provide us that normalcy again. But if we look to vaccinations, we want to remind you that it's not going to be possibly until May of next year that we have it widely available to the general population, to the workforce as well. And so what does that mean for us? It means we got to continue with our new norm of doing a daily screen, recommending those stay home who have been exposed and are symptomatic. And then our testing regimen, we got to beef it up, right? We have to figure out how to get our folks tested rapidly. And I don't mean just a rapid test at the point of care. I mean consistently accessing testing that is reliable and accurate, both locally, and then making sure our return to work protocols are fortified for the long haul, right? As we approach the winter months, we all predict in the clinical community that COVID will continue to get worse because everyone will be indoors in the northern states, in the Midwest, and abroad. And we want to make sure we have strategies that can weather that impact and make sure we're getting people back to work as quickly as possible, but at the same time maximizing safety for our workforce. And so the likelihood of this, obviously, with regard to a vaccine coming about, is going to be, again, continuing to look at the race. The EU just came out and said that it's not going to be until early next year that they're hopeful to approve a vaccine, right? We still have, obviously, some hopes of this year. Fauci just said approval hopefully by the end of this year, December. But again, we haven't seen any EUA applications for a vaccine, emergency use authorization for FDA as of yet. If we look at then distribution of the vaccine, we have big players jumping into that. CVS and Walgreens talking about administering vaccines first to U.S. nursing homes and to healthcare workers, right? And this speaks towards the strategy that will be deployed, right? Vaccinating those individuals who are on the front lines and the healthcare industry first, the essential workforce, and then those who are at high risk, 65 and over. We'll be in that first phase of vaccine distribution. That will kick off our herd immunity approach next year. But again, we're some times away from that. and our strategies need to be fortified to weather that transition until that transition happens. And so with that, we'll go ahead and hit the pause button. We'll take some questions and we'll get specific if we need to drill back to any of the concepts presented today. Thank you so much.
Thanks, Dr. Harris. We don't have very many questions this week, which is interesting development. Usually we get lots of them. I have a couple questions, and there's one that relates to it that's been submitted by one of our attendees. His question is the expectation that vaccines will provide permanent protection, or will vaccine antibodies expire, as they seem to be doing when you actually contract COVID-19? And my question is very similar to that. I'm wondering, if you've had COVID and then the vaccine comes along, you're still going to be recommended to be vaccinated? And should we expect vaccination to be like an annual thing like we expect for flu shots, because the virus is constantly mutating?
Sure. So we don't know yet from any prospective studies or observations whether or not a vaccine immunity will be long served. There is significant concern and supposition that it will not, that the immunity derived from vaccination will only last for 3 to 6 months. And in the same way we see that immunity fade, if you would, over time for flu vaccines, we're likely to experience something similar for coronavirus, SARS-CoV-2. And if we look then particularly at the question of whether or not the immunity is going to impart kind of a difference between strains that we see with similar to the flu vaccine, we don't know. There is cross-reactivity from an immune standpoint from SARS-CoV-1 and to SARS-CoV-2. Some studies say 85% cross immunity, but again, we don't know that prospectively. And Karen, present your question, the last part of your question here again for me, so I can address that part.
I'm thinking about, well, I was thinking about flu shots, but you answered that, and then I was asking about people who've had COVID, and will they still be recommended to get vaccinated? I was thinking about the shingles shot, because my mother had shingles, but they still recommended she get the shot in case she gets shingles again. It would decrease the impact of it. I wonder if there's any similarities.
And most likely there will be. So the whole concept is for those illnesses in which our immunity wanes over time, we all have heard of booster shots, right? So it's a similar concept in that even if you have coronavirus and it was a period of time ago, let's say 4 or 6 months ago, your immunity has likely waned at that point in terms of all we know to date. And so getting the vaccine will expand your immunity, so to speak, and that approach is likely what we're going to see, even if you had COVID to begin with. It would be something different if it was something similar to a long-served immunity once you've contracted the virus and or have been vaccinated. But again, we're seeing evidence to show that it won't be long-served for us, even with the vaccine, and a booster will be necessary.
Okay, here's a question about travel. Air travel seems to be safer than I thought. How about overnight train travel or using hotel rooms? And I have a question about travel also, which is how much weight should an employer give when they're evaluating exposure risk regarding the departure location and whether there's an outbreak in that location? For example, what's going on in the upper Midwest right now, where they're at a critical capacity point. So if your employee's leaving from Wisconsin, how much weight would that apply at their arrival destination as far as evaluating exposure risk?
Sure. So in terms of travel on other means of travel, trains, long automobile rides, and things of that nature, again, masks are going to be the mainstay to help protect individuals in those scenarios. And we're likely to see similarly a protective factor if masks are required. I have not seen any data to the extent we've seen with airlines that has examined the historical transmissions that have occurred or not occurred through those means of transportation. But I'm certain that those type of studies will be forthcoming as we progress through this pandemic. In regards to what's going on in the upper Midwest and whether or not there should be significant attention paid to the place of or origin of death before they arrive in their destination. Yes, the answer is clear that some states, if you're coming from a particular hotspot, will make you quarantine, and particularly in those locations like the Upper Midwest. If you're planning to travel, do your due diligence before you make those plans to see if you can actually disembark or even embark on that flight because of the relative risks of local transmission and transplanting that to somewhere else. Now, that is one of the weaknesses of the studies that have been examined from the airplane travel, which is, is the person who was tested and likely to have contracted and the transmission has occurred and likely to have done so prior to their flight and or after their arrival at their destination. And again, the studies will continue to try to tease out those nuances, but so far, all the evidence that's been demonstrated through contact tracing and through approximating when transmission is likely to have occurred point towards, again, low rates of transmission on actual mass transit via plane.
Yeah, that's really interesting. I was looking at the map today from the past week and all the red dots in the middle of the country, and it made me think of a wave, because when we look at the map over time, it seems to just kind of roll across the country, and then the wave comes again, and so it's interesting to look at it over time. We'll just take two more questions. We're out of time, but they're both about testing. Is there any progress on using testing as a reliable way to curtail quarantine periods or allow more close contacts at work?
So at this point, it's still not available to the extent that we can make across the board recommendations to curtail quarantine periods. Put another way, if we had more access to highly accurate tests, the answer is yes, we could curtail quarantine periods. We're just not there yet across the board to make those generalized recommendations as it pertains to testing being a reliable means to shorten and curtail quarantine periods. Now, what we are learning in the clinical literature is that the infectious period of an individual may be far shorter than we first understood and even secondarily understood. Some data is showing that only 7 days after becoming symptomatic or having a positive test, a person may be infectious. And so therein lies the opportunity to end a self-isolation after a positive test or a symptomatic individual. Now, with the testing regimens we recommend from a preventative strategy, right, certainly those are in place to help and maintain individuals in a safe bubble, quote unquote, type atmosphere, as we're doing, let's say, in the media and movie industry, TV and movie industry, where they're testing multiple times a week. That strategy is going to be the strongest strategy to maintain the workforce in a healthy, productive state, limiting transmission, and that we're seeing across the board, even at universities and sports organizations. But outside of that, again, post-exposure, post-symptomatic return to work acceleration is not yet reliable due to limited access to good, high efficacious testing across the board at a cost that's not prohibitive.
Right, the caveat. One last question, we're out of time, but this is an interesting one. One of our attendees has no symptoms and no reason to think they've had exposure, but they wanted to get tested, but they were told by a drugstore that they weren't qualified to get tested because they didn't have a reason to get tested. So they're wondering, is it still being encouraged to test people with no symptoms or known exposure or not?
Sure. So surveillance testing is still limited due to, again, the level of tests available in the U.S. We're still hovering around that million on a daily average, right? We're supposed to be at 12 million by now, according to high level reports back in the spring, right? So because of that, they're still in certain jurisdictions limited to only testing those who have had exposure or are symptomatic. And that, unfortunately, is the status that we're in. I know anecdotally, my sister and her family in Florida said that in Hillsborough County, Tampa, you can go pretty much anywhere and get tested anytime you want. And we have not seen that across the board in all jurisdictions, unfortunately.
Okay, that's great information. Well, that concludes our session. For those of you whose questions did not get answered, please check the written version. In a few days, we'll have that posted. And, the holiday season is coming up. We invite you to submit potential topics, issues you may be thinking about between now and the end of the holiday period, or anything else that you see in the news and you have questions about. Please submit those to us. You can send it directly to me at karen.o'hara@workcare.com or via the chat right now or next week. Dr. Harris and I always try to keep our information as current and relevant as possible, so your input's appreciated. Thanks again for joining us. Take care, wear your mask, be safe.
Thanks, everyone. Take care. God bless.